First of all, I would take a full history. A comprehensive history is really important in establishing if there's anything sinister going on. Even in the absence of papilloedema or a visual field defect, there still could be a serious cause. Of course, the diagnosis of the headache could be quite easy. It might be easy to establish that it's caused by migraine or cluster headache or temporal arteritis. If in a patient over the age of 50 who had increasing headaches or increasing severity, or they were new onset, it may well be suggestive that these are a tumour-associated headache, and in this case I would go further and investigate further. I would ask about any focal symptoms such as weakness in the arm or the leg, or if there were any evidence of any focal seizure activity such as hallucinations, problems with the sense of taste or smell. It would also be important to find out if there are any changes in memory or in personality, and a relative may be able to help in this case. The examination by the optometrist would be fairly comprehensive, so I would go on to check the patient's blood pressure, to do a full neurological examination looking for asymmetry between the reflexes, tone and power. I would also assess memory and personality. If I felt the history was normal and the examination was normal, I would reassure the patient and treat them appropriately. If I felt there were some worrying features in the history, I would review them again in a few days' time and maybe ask them to bring a relative back. If I felt things were worsening and the headache was increasing in severity, I would then refer on for further investigations. There are two ways that we could refer. If we felt it was worrying, we could refer urgently through the computer system and refer directly to the neurology department as an urgent referral. If I was worried that it was particularly urgent, I would phone the on-call neurologist and ask for them to see the patient for me. Take a good headache history. Not all headaches in patients with brain tumours are due to raised intracranial pressure. Patients with raised intracranial pressure rarely have visual symptoms, and papilloedema is uncommon and can be difficult to diagnose. Patients with hemispheric brain tumours will sometimes have asymptomatic homonymous visual field defects. Check the visual fields and fundi in all patients with headaches where you suspect a brain tumour. The presence of headache and papilloedema is an emergency and should be referred and seen on the same day. In someone with headache and a possible field loss or odd-looking disc, use the same day or next day optometry services to confirm changes. Headache alone is a very uncommon presentation of a tumour at hospital, less than 2% of all tumours, but a common symptom in brain tumours. Watch out for headache plus. Patients with personality and memory change rarely complain of it. Ask the patient or partner directly about this if you are concerned about the description of the headache. Review patients where you are concerned about tumour-related headaches, but there are no other symptoms and signs.